Good afternoon, and welcome to our virtual town hall focused on key elements of Johns Hopkins University's updated and existing COVID protocols and policies. I'm Lainie Rutkow, professor in the Bloomberg School of Public Health, and I serve as senior advisor to President Ron Daniels. I'm one of the team members leading our COVID planning efforts. I'm pleased to be moderating this session with three of my university colleagues who are part of our COVID planning work. Today, I'm here with Stephen Gange, Professor and Executive Vice Provost for Academic Affairs, John Links, Professor, Vice Provost, and Chief Risk and Compliance Officer, and Meredith Stewart, Interim Vice President for Human Resources. Before we begin, I want to acknowledge that this has already been a very long pandemic, personally and professionally, for all of us. And I, along with the COVID planning team, want to thank you for all of your ongoing efforts to keep yourselves and our community safe. The goal for today's session is to discuss some changes to the university's operations and to reinforce the importance of our ongoing requirements and guidelines. We continue to plan for a return to in-person learning on January 24th for the spring 2022 semester and to navigate challenges posed by the Omicron variant. Importantly, we want you to know that although case counts continue to rise in our area and among our affiliates, we continue to see no transmission of COVID-19 on campus or in our workplaces when our rules and guidance are followed. Having said that, we're mindful of COVID-19 spread in the community and of the strain on our healthcare colleagues. Before I turn things over to our panelists, I want to take a moment to describe the consultative process that accompanies our planning. First and foremost, our priority has always been ensuring the health and safety of our community to the best of our ability, and we continue to be guided by our medical and public health experts in responding to this evolving pandemic. We've assembled multiple COVID-specific groups that routinely provide advice, consultation, and feedback to university leadership. These groups include a health advisory group composed of leading Hopkins public health and medical faculty experts, a student advisory committee, which includes representatives that span our student body, and a university pandemic academic advisory committee, which includes faculty representatives from the university's different schools. We continue to employ a framework of 3 phases of operations based on state and local regulations and our own experts' assessment of the public health situation. We're currently in phase 3 of our reopening plan with the resumption of higher density activities. Below this screen, you'll see a box that will allow you to send in questions in real time during today's session. We will answer as many of the questions submitted by participants as we can. And like our other town halls, this one is being recorded and it will be available for asynchronous viewing. I'm now going to invite each of our panelists to give opening remarks. First, I'm going to turn to Stephen Gange. Stephen will be speaking about the current epidemiological situation and how this evolving science has informed our guidelines and planning. Stephen, over to you.
Thank you, Lainie, and thank you. We knew that January would be a challenge, as many headwinds were against us. I think even what we've seen has surprised us. So as I think you all know, the CDC defines a high level of community transmission as more than 100 cases per 100,000 in the last 7 days, or a positivity greater than 10%. As of this week, all 50 states and many metropolitan areas are over this level. Some of them a little bit, such as Idaho at 228, and some of them a lot, such as New York City at 3215. The most recent data from Maryland also point to a high level of community transmission. Maryland is reporting more than 10,000 cases per day, a positivity rate of over 25%, and Baltimore City itself is exceeding that rate. In addition to the number of cases, hospitalizations are of concern. I think the state illustrated concern when there were more than 2,000 individuals hospitalized and initiated certain emergency actions. Here in Maryland, we just exceeded 3,100, and the forecast is for this to increase over the next several weeks. Several hospitals have started to institute crisis standards of care. Here at Johns Hopkins, we've been monitoring the case reports among JHU affiliates. Similar to what we're seeing in the community, the case rates here have increased as well. As of a couple of days ago, we had over 450 employees report new cases in the last 7 days and nearly 200 students in the last week. We recognize that the situation is challenging. We're fortunate, as Lainie said, to still see no evidence of classroom or lab transmission. The cases that are occurring in the community, with families, with travel, and just the kind of transmission that challenges all of us. We believe that our ensemble approach to campus has helped prevent transmission in classrooms and lab settings, and want to emphasize again the importance of the ensemble set of approaches that we've taken, including mandatory vaccinations, requirements of indoor masking, increased ventilation and filtration of air, testing, and fully staffed Johns Hopkins Clinical COVID Center. But we know that with Omicron, things are different. There is evidence, as reflected in the community numbers, of increased transmissibility, and we have taken some steps to do some things differently. What have we done differently? Well, first of all, we moved some activities online. In particular, a number of winter intersession programs were moved, instead of being in person, to online. Meredith will talk a little bit later about increased flexibility in terms of work schedules, but I think it's important to remember campus is open. Labs are open. There are students in the dorms, not a large number as usual, but still students in the dorms, and activities are going on. In-person activities are going on campus. We are anticipating that this surge will rise and begin to decline in the next several weeks, and coupled with the changes that we're making, that it will allow us to continue for an on-time start to the spring semester. One of the other changes that we implemented, as you all know, is a booster mandate. Again, this is part of our overall number of changes. I think that our health advisory group and other accumulating scientific evidence is clear about the value of boosters. The waning immunity of just vaccination over the course of time is becoming clear, and the value of boosters from clinical trials and other clinical evidence is irrefutable. As you all know, boosters are required for all faculty, staff, postdoctoral fellows, and other students who work and study at a Johns Hopkins U.S. campus, and must be completed and documented in the vaccine management system by February 1st. To help We encourage, if you're a student at home, please go and get your booster whenever possible. But in order to help improve the accessibility to boosters, the university has scheduled a number of clinics where JHU affiliates can receive booster shots. The first of these booster clinics actually is occurring tomorrow at the Homewood campus between 10 and 4 p.m. We have 3 clinics scheduled next week, 2 the following week, and a series of clinics scheduled throughout the rest of January. So if you have not yet received your booster, please attend one of these clinics or get your booster at your healthcare provider or at one of the commercial pharmacies, and be sure to upload your documentation by February 1st. We will be following up individually, just as we had with vaccines in the fall. We've made a number of other changes to testing and quarantine, and for that, I'm going to turn things over to John Links.
Thanks so much, Stephen. We'll now hear from John Links, who will talk about measures to mitigate the health effects of the pandemic within the Johns Hopkins community and how some of these measures have recently changed. John, over to you.
Hi, everyone. So the new variants, particularly Omicron, have different behavior than past variants, and that's at both the individual person level and at the population level. And when we think about current COVID behavior, it is more asymptomatic and mild disease with a shorter incubation period, and a person who's infected is most contagious over a 3 to 5 day period that straddles becoming symptomatic or having a positive test. And what that means is we need to double down on early detection rather than lengthy isolation and quarantine. So the first important change is that we've increased mandatory testing of all students, that's undergraduates and graduate students, who come to campus to 2 times per week. And those 2 tests must be conducted at least 48 hours apart. Unvaccinated faculty, staff, and postdoctoral fellows, with an approved exception, are still required to test twice weekly as well. And we continue to offer voluntary asymptomatic testing on demand for faculty, staff, and vaccinated postdocs. I should remind you that the School of Medicine continues to follow Johns Hopkins medicine policies rather than the prevailing JHU policies. That's the first change. The second change is that we've made changes to both isolation and protocols for quarantine. So with respect to isolation after testing positive, those who have tested positive must have no symptoms at 5 days in order to leave isolation. Otherwise, they remain in isolation until they're free of symptoms. And at this point, we are not requiring testing out of isolation. It's symptom driven. With respect to quarantining after being exposed to someone who is COVID positive. And remember, a close contact is still someone with whom you are within 6 feet for 15 minutes or more. Those who are vaccinated and boosted who have had a close contact do not need to quarantine. And that reflects the literature that Stephen alluded to in terms of the power of boosting. Those who are either unvaccinated or vaccinated but not yet boosted and have a close contact must quarantine for 5 days. Anyone with a close contact whether they're vaccinated and boosted and therefore not in quarantine, or others who are actively quarantining, will need to test negative at 5 days. So 5 days in, you'll need to have a asymptomatic test to get out of quarantine. And here too, School of Medicine affiliates will continue to follow Johns Hopkins Medicine policies. Lainie, back to you.
Thanks, John. I'm now going to turn to Meredith Stewart, and Meredith will speak about workplace flexibility and related issues over the next few weeks. Meredith, over to you.
Hi, everyone. Just a few comments on workplace flexibility. So in our message that went out on December 31st, we communicated some additional flexibility around coming to campus to do your job. The idea is that this will help keep the campus dedensified as much as possible heading into the spring semester. It also gives our community some time to get beyond the period of increased exposures from holiday gatherings and travel, and help with other disruptions that are being caused by the current Omicron variant. So as Stephen mentioned earlier, the university remains open for all planned research and clinical needs, to support students who are on campus and to make necessary in-person preparations for the spring semester. But to the extent where you can perform your job at home or work remotely, please work with your division to arrange that. We are planning on returning to our normal workplace modality on January 24th. And if you have questions about your specific situation, you should be in touch with your manager, and Divisional Human Resources is also able to help you. Lainie, back to you.
Thanks, Meredith. I'm now going to turn to the many questions that have been coming in. I want to thank everyone who's watching and submitting questions in real time. And I want to encourage you to continue submitting questions throughout this session. I promise you I am keeping a very close eye on your questions coming in. And of course, our panelists are anxious to answer them. So, John, I'm going to first turn to you. No surprise, we're having a lot of questions come in related to boosters and the general utility of boosters, given that we, all of us, continue to hear about so many so-called breakthrough infections.
So I totally understand the question. And first, let me say that if this pandemic's taught us anything, it's humility. So anything that we tell you about what the science indicates is really a reflection of what we know at the moment, not some grand absolute truth that holds for all time. And certainly the behavior of the variants is so variable from variant to variant that even if we're positive about something now, it doesn't mean that that same truth will hold for future variants. So with that proviso, what we're seeing with the immunity from the original vaccinations in folks is that it wanes over time. How rapidly it wanes depends on a lot of individual particulars of that person's health status, immune system, and things that drive it, such as age. And so we can't make sweeping statements about how long a good level of immunity lasts after vaccination, but we have seen across everyone that it wanes at a variable rate over time. That's the logic of a booster. And what we've then seen is the effects of a booster, in fact, do boost immunity, typically back to the original vaccination levels. And so you can think of the booster requirement as not necessarily being any different than the annual flu shot requirement. So we require a flu shot each year, not just a flu shot once in your lifetime. Now, of course, right now, the analogy isn't perfect. With the flu shot, it also has to do with the fact that it's a different set of potential variants each year. With the boosters right now for COVID, it's a general boost. It's not a variant specific boost. But in the future, for all we know, we're going to see more variant specific boosters. And we'll take that into consideration as well on an ongoing basis. But we strongly believe in the power of boosters, and that's why we've mandated them.
Thanks very much, John. I'm going to stay with you and ask a question about masking, and this is an amalgam of several questions that are coming in. It feels like we're increasingly hearing that cloth masks are of less utility against Omicron. What is the university's current thinking about masks? Not should we do it, but what types of masks should we be using?
So there's a saying that the great is the enemy of the good. And I think that's what we're kind of suffering from a bit here. So when you think about masking, there are really two considerations. What's the mask made out of? And how does it fit? And are you wearing it properly? And you can have a mask made out of the greatest mask material in the world. And if you're not wearing it at all in certain high transmission settings, and you're wearing it improperly in others, it doesn't matter that it's made out of the greatest material in the world. For us, the most important thing right now is that you wear a mask and that you wear it properly. So it's covering your nose and mouth. You're wearing it consistently. It's a mask of a size and shape that properly covers your nose and mouth without gaps around the edge of the mask, because then you're just breathing air in around the mask rather than through the mask. That to us is the most important. If you're doing that properly and you're using a multi-layer cloth mask, we think you're fine. We are not going to mandate, for example, the use of KN95s or N95s. If you feel more comfortable using a KN95 or an N95, we're totally fine with you doing that. Just make sure it's a real KN95 or N95, not a fake. And that's great. They also fit nicely in general. But again, it's about consistency of mask wearing and proper mask wearing, and a properly fitting mask does that.
Thanks very much, John. Stephen, I'm going to turn to you now. Several questions coming in about plans for the beginning of spring semester and classes. What is the current thinking for classes at the beginning of spring semester in terms of in-person versus virtual?
So, we've weathered many, ups and downs over the last several years about in-person classes. I think the value of in-person instruction is part of our ethos, and we have online programs. We have great online programs, but for those programs that are designed to be in person, we want to get back to that environment. And so, we made some changes over the next several weeks, largely with an eye towards trying to start spring semester in person and on time. So currently we don't have any plans for moving our beginning of our spring semester online, but we are constantly watching the situation, and we'll make changes as necessary. As been highlighted, the classroom setting right, is not an area of high risk or any risk from what we can see. It's acquisition of COVID in the community and outside of the classroom setting. So our plans are not expected to change in the next several weeks.
Thanks, Stephen. And a follow-up to that question, will the 50-person limit remain in, or do we anticipate that it will remain in place for classes and indoor activities?
So we've been working with the schools on evaluating the various activities greater than 50 students. So I would say that even in this past fall, it was not a hard limit, right? We worked, very carefully with schools to define what activities might proceed, even if they were greater than 50 in a classroom as part of another indoor setting. We're continuing to do that. I think that there is, again, value to, from a pedagogic standpoint, as well as other benefits for in-person teaching that I think faculty want to bring back. And so we're working with the dean's offices on that planning.
Thanks, Stephen. John, question for you about our indoor masking policy. Can you clarify for employees who are in offices where they can shut the door? If their door is open, what should they be doing?
The answer is masking. So the exception to universal indoor masking in a private one-person office is if the door is closed. So if the door is closed, you're in your own office by yourself, you can take your mask off.
Thanks, John. And a related workplace question. Can you speak, you touched on this, but can you go into a little bit more detail about the mitigation measures that are in place to keep those safe who are in shared offices or open cubicles?
So, as Stephen said, we're relying on an ensemble of measures, not one single magic bullet that keeps us all safe. And it starts with our mandate for vaccination and boosting, then moves to masking, then testing, then ventilation, which I've spoken about numerous times in previous town halls. And all of these are working together to keep transmission at this point in terms of documented cases at zero in a classroom or lab setting. In a office setting, we also have had no documented case of office-based transmission, except a couple of times when our rules were not being followed. People weren't masking, etc. And so when our rules are being followed, there has been no documented case of on-campus transmission.
Thanks, John. Meredith, a few questions for you related to workplace safety and flexibility. The first is for those that are concerned, especially if they're in a shared office space and others are not being compliant with masking, what is the right thing for them to do in terms of HR?
So there's a speak to us line, and this is a typical way we get these types of concerns raised. There's a speak to us line if you want to go about it that way. You can also speak to your HR, divisional HR person. But either way is fine. Those usually get funneled out to HR, and HR handles those and follows up.
Thanks, Meredith. different question about workplace flexibility in the coming weeks. So for those that typically are required to report 5 days a week, what might the next few weeks look like for them?
So workplace flexibility is handled division by division. And so where people can do their work remotely, that flexibility may be offered by the division. So my advice, because it is so specific to each division, is to speak to your manager or supervisor. And again, HR is also able to help with those.
Thanks very much, Meredith. John, question or clarifying question about something that you mentioned in your opening remarks. Why are we now saying that the number of days for isolation is symptom driven as opposed to having a test out option?
So we know that the time course of the illness in individual people is much shorter than it was with the original coronavirus. And so the symptoms are a reflection of viral load, which itself is what tends to drive contagiousness to others. And so we're putting our focus on being symptom free as an indication that the viral load is so low that the person, particularly in the context of our universal indoor masking mandate, is no longer infectious or contagious to others, that is no longer poses a risk to others. In that regard, I'll note that our rule is stricter than CDC's, who says symptoms simply have to be resolving.
Thanks, John. And I'm going to stay with you and ask if you could speak to the university's current travel policy.
So, some of you may know that Johns Hopkins Medicine sent out a message reverting back to essential business travel only. We have not done so. That's not because we think everyone should be traveling everywhere left and right. It's because we think it's obvious that people shouldn't be traveling everywhere left and right and don't necessarily need us to tell them that. Even in normal times, folks can't just automatically travel wherever and whenever they want under the aegis of the university. And so the normal checks and balances certainly would capture inappropriate travel, that is travel where the risks outweigh the benefits of the travel, which is really what's conveyed by the notion of essential business travel only anyways. So we haven't at this point bothered to change our formal travel guidance in terms of COVID, but we're expecting that everyone is understanding the heightened risk of travel right now.
Thanks, John. Stephen, I'm going to turn to you with some academic related questions. The first is, assuming that we're in-person classes at the beginning of spring semester, how does it work if a faculty member has a student in their in-person class who tests positive for COVID?
So, we are continuing the policies that we implemented last year for notification. So the Johns Hopkins Clinical COVID Center will continue to do contact tracing and notification for anyone who is a close contact of someone who is infected. We are not broadly broadcasting if there is someone who is positive, but instead relying on the conversation that the JHCCC team has with the individual to identify those individuals who may be close contacts. So we are not doing broadcasts about individuals who may be positive in any setting.
Thanks, Stephen. In some ways, the flip side of that question, if a student is positive and has to isolate, will they continue to have access to their classes? How will that work?
So, this is certainly a challenge to say broadly, right? Not every classroom, an organic chemistry laboratory, right, can't be duplicated on Zoom the same way that a lecture may be duplicated on Zoom. And so I think it really, the dean's offices and instructors all know the situation, and just like in normal times, as instructors, one manages when students are sick, when they're traveling, and may need to gain access to materials or information that is offline, or make up assignments. So I think that there's no broad statement. Last spring we had a particular mandate of all faculty because we were not anticipating all students coming back to campus, right? We changed that this fall and managed that division by division and program by program, how faculty members would account for students who may not be in class. So I think that will continue. I don't think anyone is not aware of the current public health conditions and the fact there may be a substantial number of students who at any one time are not in class. And so faculty will continue to have, the same kind of leeway for providing material and making up assignments.
Thanks, Stephen. John, a couple questions coming in related to something that you mentioned about KN95 masks. Do you have advice for those who want to make sure that they're getting real, not fake ones, and how to tell?
So at the point when there was a point when KN95 masks were under an emergency use authorization, and CDC and NIOSH put out a list of approved KN95s, and you can Google for that list and then compare whether the mask you're thinking about buying was on that list or not. That's one way of doing it.
Okay, thanks, John. That advice is helpful. And a different masking question. So if Hopkins affiliates are seen wearing gaiters on campus, what is our policy and what is the right thing to do?
A gaiter does not count as a acceptable mask for us. And so you would do the same thing you would do if you saw someone not wearing a mask. You would report it. The same is true, by the way, for a mask that has an exhalation valve. That defeats the purpose of the mask protecting other people. The mask is there to protect you and to protect other people. And so gaiters and masks with exhalation valves are not allowed.
Thanks, John. And I'm going to stick with you now for a testing question. So we've spoken in previous town halls about how those who test positive for COVID may continue to come back positive, especially on a PCR, long after they're past an isolation timeline. So how do we handle it at the university when someone has tested for COVID in terms of them going back into the testing pool?
Okay, so the behavior of different tests is different. So I'm going to say specifically answer the question and then say a little more. So the saliva-based asymptomatic testing that we're doing, that is the mandatory testing program, is nucleic acid PCR. So it's testing directly for nucleic acid of the virus through PCR. It is an extremely sensitive test. Because it's extremely sensitive, a person who had the virus may still have nucleic acid fragments, or in fact, very, very low levels of intact virus for a long time. So we say, in terms of the asymptomatic testing program, they are exempt from that program for 90 days. So even if they are a student who now otherwise would have to test twice weekly, if they were positive, they do not have to test twice weekly. Now, if they become symptomatic again, they need to call the JHCCC, who may in fact order a diagnostic COVID test, may order a flu test, etc. So it's not like you have a complete get out of jail free card for 90 days. You don't have to do the routine asymptomatic testing, but if you're newly symptomatic, you could in fact be reinfected. And so we want to know about it. Okay, that's PCR testing of nucleic acid. Home test kits, and in fact, some of the testing we are doing of symptomatic people at Johns Hopkins Medicine, is antigen testing. Particularly for the home test kits, those kits are less sensitive at detecting very, very low viral loads. Paradoxically, that makes them at times more useful in determining whether someone is significantly infectious to others, because you need a higher viral load for those home test kits to turn positive. So depending on the purpose of the testing, you may want a less sensitive or a more sensitive test. We think the home test kits complement but do not replace either diagnostic PCR testing or our own asymptomatic testing program.
Thanks, John. I'm going to ask you one more testing question and then we'll change topics. How was the decision made for students to move to twice weekly mandatory testing as opposed to other Hopkins affiliates?
So at the end of the day, what we're trying to do is maximally protect our entire campus community, students, staff, and faculty. And we're deploying our resources to try to do that optimally. Through our own contact tracing, honestly, from the beginning of the pandemic, what we've seen is that students give other students COVID because students hang out together off hours, off campus. But faculty and staff do not give each other COVID because they don't hang out together off hours, off campus. And so the biggest bang for the buck for us is to focus the mandatory testing on students, because each student we catch early with COVID does more to protect the rest of our community, students, staff, and faculty, relatively speaking, than is the case with staff and faculty.
Thanks, John. Stephen, question for you. For international students who are getting concerned about travel and returning to campus, what advice do you have?
So, I think I've said on previous town halls, I'm a parent of an international student myself. who is currently here and scheduled to go back overseas at the end of the week. So completely understand the concerns. So one, the things that we can't control, such as flight delays and cancellations and rescheduling, just makes it a challenging time, and we recognize that. Our advice is to try to plan flexibly, and if you do have problems returning, please reach out to student affairs folks, and if they need to connect you with other resources, they will. In terms of protecting one's self, I think all of the basics continue to apply, of ensuring that you're wearing a well-fitted mask when you're traveling, and working to minimize exposure as best you can to others. The processes, that we have in place, for testing and following up with the JHCCC, are all resources that are available to students, and should be taken advantage of, as well as our other university health services.
Thanks, Stephen. Different student-related question. What do we anticipate student dining will look like at the beginning of spring semester?
So that's something we're still working through. I think it will look probably similar to last fall, with a good amount of grab and go and de-densified dining.
Thanks. And John, can you speak more generally to our current policy for food at indoor events?
Yes. So right now, up until the start of the spring semester, we're asking that there be no food at events, and that also means no drinks, snacks, etc., as well as no grab and go. Honestly, indoor eating is way up there as probably the riskiest activity you can engage in, unless you're doing it by yourself. And so we're really right now, just for the next several weeks, trying to eliminate that source of transmission risk.
Thanks. And John, several questions coming in about the JHCCC. So first, we should probably review what is the JHCCC and when is it appropriate to contact them, and what to do during this current surge if you have to wait a little longer than you'd like to get through.
So the JHCCC is the Johns Hopkins COVID Call Center. It is a shared resource between the university and the health system. It is staffed by a combination of occupational health and student health professionals. From the time it was instituted, it is meant as your point of contact when you have symptoms or are otherwise concerned that you may have COVID. It is who you hear from if you have a positive test. It is how contact tracing is carried out. As you can imagine, the JHCCC is absolutely slammed right now. You can think of it as no different from what you're hearing about hospitals, about testing centers, and about all other aspects of COVID response. So it is super slammed. We are trying to add more staff as rapidly as we can, but it's slammed. It's just a fact of life of where we are in the pandemic right now. We're not happy about that, but it is what it is. It means people are on hold for a really long time. So as an alternative, there are online forms you can fill out, and then you'll get a call back, usually later that same day. And we're trying to implement a number of other changes to streamline the processes as well as adding staff. We just ask for your patience. We get it. It's frustrating. And we're working really hard to try to beef things up.
Thanks, John. Stephen, will students be required to test prior to returning to campus?
No. Students don't have to test prior to returning to campus. As John has outlined, we have an on-campus testing expectation, as well as infrastructure for taking, getting samples, doing the testing, and integrating that with the rest of our processes. So it is certainly not prohibited if a student wants to go out and get a test before they travel, but it's not required.
Thanks, Stephen. And I'm going to stay with you for another student testing question. For students who live off campus but take classes on campus, how many times a week do they need to test?
So the mandate is for twice a week testing that we just implemented. That applies to all students on and off campus.
It applies to all students who come to campus, whether they live on or off campus.
Yeah. If you're an online student, a student that doesn't interact with the physical campus, you do not need to test. And within Prodensity, I think we've promulgated this, that if you're not going to come to campus, you have an ability to signal that within the app itself. And we encourage both, I think, employees and students to utilize that function to signal to the system that you're not planning to come to campus. And that will certainly, for students who have a mandate, signal that we're not expecting you to come to campus and you won't be highlighted as being out of compliance.
Thanks, Stephen. John, a question about eating while on campus. Now that it is the winter and it's much colder and outdoors has become less of an option, thoughts and advice for those who are on campus and don't have a private office?
There remain designated eating areas. You should maintain distance while eating because you're obviously unmasked, and so the distance is to compensate for the unmasking. And we're trying to provide as many of those areas as we can. And so, back to my earlier comments about no food for events, we're just trying to cut down on the more discretionary communal eating, understanding that there are folks who don't have a choice. It's not discretionary. They have to go to a indoor common area to eat.
Thanks, John. Another question for you about the booster mandate and timing. What should folks do who will have a challenge to meet the deadline for the mandate? Let's say that they currently have COVID, for example.
So the February 1st deadline only applies to those who are eligible by February 1st to receive a booster. You may not be eligible depending on when you got your original vaccination series. You may also not be eligible depending on if you're sick with COVID. By the way, you can get boosted as soon as you recovered. There's no waiting period, unless you were treated with monoclonal antibodies, in which case there's a 90-day waiting period. what you would do is request a medical exception in VMS, and we would give you a time delimited approved exception.
Thanks, John. Stephen, question for you. How much do we follow what other colleges and universities are doing locally, but also throughout the country? And what role does that play in our own planning processes?
So we're in, communication with at various levels, with student affairs folks, with other provosts, with other leaders at other campuses. In some cases, we've shared access to data. So this is not decisions that we're making not being informed by what's going on at other schools. That said, we have emphasized that the decisions that we make are taken with our experts here at Johns Hopkins and in account of our special situation, whether it's here in Baltimore, the nature of our campuses, et cetera. So I do think that we are informed by what's going on at other campuses, but certainly make decisions individually that are the right ones for us.
Thanks, Stephen. And since we're coming up to the end of the hour, I'm going to give you the last word. We do have some questions coming in about availability and accessibility of boosters. I thought you might want to say something about our upcoming clinics.
Sure. So again, we don't mandate you get your booster at a Johns Hopkins clinic. If you want to get it at a pharmacy, if you want to get it at your healthcare provider, if you want to get it at a city clinic, those are perfectly valid places to go and get a booster. We're offering a number of clinics here at Johns Hopkins to help facilitate the accessibility to boosters. The first one is tomorrow on the Homewood campus, and we have a series of multiple clinics, some of them on Homewood, some of them in other locations across Baltimore, or even we're working to get them down in DC as well. So what I would encourage everyone to do, our central source for information has always been our COVID info website. If you don't know the website, it's covidinfo.jhu.edu. That has all of our policies and a whole set of FAQs as well. If you click on the vaccination tab at the top of that website and click under upcoming clinics, you can see the listing of dates and times and locations for all of our clinics. And so please continue to use that as a central resource. We are trying to keep it as updated as possible. It has a listing of all of our university communications. It has a whole set of FAQs and other information, as well as links out to other resources such as the Johns Hopkins CCC as well. So please continue to use that and send us feedback if there are things on there or questions that aren't answered. We're happy to continue to modify that.
Thanks, Stephen. And with that, I'm going to close out this town hall by thanking all of you for joining this afternoon and for your continued efforts during these disrupted times. I know that we weren't able to answer every question, but I do hope that this session has provided further clarity about our planning for the next several weeks and into the spring. This session has been recorded and it will be made available as with our previous events. I want to thank you for your diligence and care in maintaining good public health practices. And as always, stay safe.